Hello, my name is Albert Messiha. I'm a student at the NTPD program. Today I'm going to represent my patient case. Her name is Tori Simpson. She is 62 years old, Caucasian female. She is married with two adult children. Also, she is covered under Colorado Medicaid. Her family history is that her mother deceased at the age of 82, her father died of myocardial infarction at the age of 70, her sister had a history of breast cancer and diabetes. Also, her brother had a history of heart failure with reduced ejection fraction, diabetes, and peripheral vascular disorder. She came to the clinic today stating that she is suffering from worsening of lower extremities edema with shortness of breath with normal daily activities. Also, she is suffering from menopausal symptoms like vaginal dryness, pain during sexual intercourse, and pain during urination. Her past medical history includes diabetes, hypertension, dyslipidemia, chronic kidney disease, menopausal syndrome, primary prevention of cardiovascular disorder, heart failure with reduced ejection fraction, osteopenia, gastroesophageal reflux disorder, and obesity. My assessment of her current heart failure condition is that she has uncontrolled heart failure with reduced ejection fraction. According to the physical exam and the lab results from today's visit, I would classify her with a stage C heart failure according to the American Heart Association, and according to the New York Heart Association, I would classify her with class 3 heart failure, which is defined as marked limitation of daily activities. Also, her ECG from today's visit showed sinus rhythm of at 64 ppm, no ST segment elevation, also evidence of left ventricular hypertrophy. Her echo from 3 months ago showed ejection fraction of around 37%. My assessment of her current therapy is that it's according to the current guideline. However, the treatment plan prescribed for the patient is inadequate to relieve the current symptoms, and she has worsening of heart failure. Currently, she takes Lasix 10 milligram twice daily, Carvedilol 25 milligram twice daily, chlorsalidone 12.5 milligram once daily, lisinopril 40 milligram once daily, amlodipine 10 milligram once daily. However, with all of this medication, she has uncontrolled heart failure, and the current therapy is inadequate to relieve the symptoms. My therapeutic plan recommendation. I started with non-pharmacological intervention, which includes cardiac rehabilitation, exercise and training programs, diet and nutrition plan, also sodium restriction, sodium dietary restriction to 2 or 3 grams per day, restricting of fluid intake to 2 liters per day. My pharmacological treatment intervention, I started with changing the Lasix dose to 20 milligram twice daily. Then I discontinued the lisinopril, I discontinued the amlodipine, I discontinued the chlorsalidone. I want to recommend continuing the spironolactone 25 milligram once daily, the carfentanil 25 milligram twice daily. I wanted to initiate Fraxiga 5 milligram once daily. Also, the Entresto, which is an ARNI class of medication, 49/51 milligram oral tablets. Direction: take 1 tablet by mouth twice daily. And there should be 36-hour wash out period between discontinuing the lisinopril and initiating the Entresto medication. My rationale of choosing this therapy plan is that in patients with heart failure with reduced ejection fraction, the Entresto or the ARNI class of medication is recommended to reduce morbidity and mortality. Also, for fluid retention, diuretics are recommended to relieve congestion and improve symptoms of edema. Also, it's recommended for heart failure with reduced ejection fraction to start sodium glucose transporter inhibitor to reduce hospitalization and the cardiovascular mortality. Also, I discontinued the calcium channel blocker because the study showed that it doesn't add any benefits for the patient. For monitoring, I recommended to monitor the safety and the efficacy of the medication after 4 weeks. Labs that should be ordered includes blood glucose level, liver function tests, bilirubin, serum creatinine, electrolytes, serum uric acid, serum potassium, and a follow appointment should be scheduled within 1 month. For the second health issue, which is monopause, the patient is noting an increase in menopausal symptoms, in particular vaginal dryness, pain during intercourse, and pain during urination. She has tried other over-the-counter medication like vaginal lubricants, Astroglide with intercourse, and twice weekly she used Reblens, which is kind of vaginal lubricant as well, but it didn't help her out. That's my assessment of the disease. The current therapy is inadequate, as the patient tried alternative therapies like lubricant gel and the other modalities per current guideline recommendation, and she still suffers symptoms with sexual intercourse and other symptoms. My therapeutic plan, um, my therapeutic plan includes non-pharmacological intervention, which includes lifestyle changes, diet to limit spicy foods, alcohol, hot drinks, exercise, stress reduction and smoke cessation, behavioral therapy that includes stress reduction and progressive muscle relaxation. My pharmacological intervention for her menopausal health issue is to start estradiol 0.01% vaginal cream. Direction is to insert 4 gram vaginally daily for 1 to 2 weeks, then gradually reduce to one half the initial dosage for a similar period. A maintenance dosage of 1 gram 1 to 3 times weekly may be used for restoration of the vaginal mucosa as well. My rationale is the hormonal therapy is recommended by current guidelines, and also it helps with restoring the vaginal flow, decreasing the vaginal pH, and improving the thickness of the vagina, also the elasticity of the vaginal tissue. Monitoring plan for the menopausal health issue is to order lab and hormonal levels to check the estrogen and the progesterone level to adjust the dosage of the current pharmacological recommendation of the therapy. Also, a follow-up appointment should be scheduled 1 to 3 months from the initiation of the therapy. Thank you so much.